Welcome to A Shot in the Arm podcast. I'm Ben Plumley, and this is a podcast about innovation and equity in global health because, let's face it, without equity, what is the point of innovation? Well, this is a bit of a major podcast for us today. We've got a fantastic guest who's been a friend of the pod for a couple of years now. But to kick it off, I'm joined by my co-host, Yvette Raphael. Yvette, hi, how are you?
Hi, Ben. How are you? I'm great. I'm here in South Africa just after IAS, so kind of taking a break.
Yeah, well, we were both last week just in Rwanda, and I was going to ask you how's your jet lag, but I guess it's just sheer exhaustion from the conference, right?
Yes.
Well, shall we get to it? It's an absolute honor for us to welcome back to A Shot in the Arm podcast, Winnie Byanyima, who is the Executive Director of UNAIDS and the fearless global champion at the forefront of the global AIDS response. Winnie, welcome back to the show.
Thank you very much, Ben. Delighted to be here with you.
Well, we're really thrilled we could get to chat with you. And I know Yvette and I have got a full agenda. I guess the first thing is, just before the International AIDS Society conference, UNAIDS released a report, the sort of state of the response. And I've got to say, I don't know about you, Yvette, but I'm always so impressed with your relentless enthusiasm, Winnie. Are we in a moment of crisis or are we in a moment of transformation? And I wondered if you could just sort of share for us the sort of top line findings from the report and you know how you feel about these two very sort of conflicting moments, this fork in the road.
A good question. We released our annual report, the Global AIDS Update, and we had the privilege to be hosted by South Africa, the government of South Africa and the SANA communities and government together. It was a great launch. And the report said, it was for 2024, that in 2024, we were continuing to make progress against HIV and AIDS. We had 1.3 million new infections. That is most concerning, that the infections were not going down as fast as we want them. And that, although is still 61% down from the peak in 1996. Going down, but slowly. Deaths were 630,000 AIDS-related deaths. Again, a decline, but not as fast as we want. Now, that was 2024. But the report also peeks into this year because in February, the global AIDS response was severely disrupted by the biggest provider of external assistance, freezing their resources suddenly. That disruption, we see already signs that it's going to knock us, of course, if the hole is not filled by other sources of funding. So we say it's a moment of crisis, but also a moment of transformation, because we also report about new technologies that are coming on the market that can unlock a prevention revolution, the way a treatment revolution was launched in the 2000s, 20 years ago. We talk about, for example, one of the prevention tools, lenacapavir by Gilead, that if in South Africa, for example, is provided to 5% of the adult population, that's about 1.8 million people, South Africa could avert up to 35% of new infections. So the opportunity is huge. Other opportunities are countries in the global south are not just lying down to die because big money has been taken away, even though some of them are even up to 90% dependent on external resources. We are seeing all countries taking steps to fill the gap in some way or another, putting up new taxes dedicated to fighting HIV like Tanzania, and others reallocating from their budgets. So we are seeing Global South mobilizing resources to fill the gap. We are seeing creativity in how to spend. The time of having programs that are capital intensive, well funded, producing the most amazing results is not now. Now we are seeing integration, bringing HIV into the mainstream of global health, sharing resources. It comes with risks, no question. One of the biggest risks is civil society, and we mentioned this in the report, that without communities at the center, many countries will backslide because they can't reach the people in need the way communities do for themselves. So risks are there, but opportunity for change is there. I talk about decolonizing. It's an opportunity for decolonizing because it's an opportunity to say, within the means a country has, how is it going to deliver a response? It will look different, but it must hit those targets that we set. So it's a moment of decolonizing.
There's so much to unpack from what you've said there, Winnie, and I think Yvette and I pretty much share, I'd say 99.9% of what you've said, but I know Yvette is champing at the bit to sort of comment and ask about community leadership. So Yvette, over to you.
Yes, definitely. And thank you so much, Winnie, for your dedication and also for your commitment. And we were grateful that the report was launched in South Africa. Unfortunately, I was not around, but obviously all of the social media showed that. When we talk about communities, I want to hear from you. How do you think we are faring? I know you were around some of the communities, meeting the communities in most of the countries where you were, and that is some of your passion. Tell us, how are they faring? Community-led monitoring and community-led organizations and work usually is the first to be cut off. Did that conversation happen with our leaders in Africa?
Again, a good question. But by the way, I saw your op-ed just after I left. Brilliant. Congratulations on that.
Thank you.
The picture is different. It's mixed. There are some countries, surprisingly, who had already been recognizing and supporting the role of communities in delivering services and in advocating for themselves. So those countries are not finding it difficult to step up some more and maintain that role and even support it more. I've just come from Cote d'Ivoire. Cote d'Ivoire is one such country. 80% externally funded, but throughout its health system, not just HIV, there have been NGOs, national and international, that are part of health service delivery and that get funding from the government. So they have also been doing some work with civil society, but not much. But now I left when they have actually made a new allocation to fill the gap that is going to be going to their AIDS fund, to communities, and they're even going to support our role as UNAIDS in the country because we are scaling down also. So there are countries where it's already happening, but there are countries where it's problematic.
Yes.
Where not only will they not fund because they don't see the role, but they also see civil society as enemies and crowd them out and hide from them. So we have some challenges in quite a number of countries. And the third thing about communities is that this defunding, this cutting of resources for the HIV response and development in general, it's not just the United States, it's also by European donors who have been doing it more gradually, but are also increasing their cuts. It's accompanied by a pushback on rights as well.
Yes.
That from those countries themselves, there is a pushback on rights, a pushback against international cooperation, against migrants, against there's a rise in racism, a rise against the rights of LGBTQ people, rights of women and girls. So we have a double challenge, funding challenge and a rights challenge, and we have to stand firm and defend rights.
Yeah.
We know, for example, that some of the countries that are cutting our funding are also asking us to walk away from language we had already won. Yeah, so it's serious. But a country like yours, I found in South Africa that there was a tough conversation going on between yourselves and the government, and you were trying to make them honest about the gap. You had done your analysis and you're saying, look, this is how critical the gap is, and also tell us how you're going to close it. And you could see a government struggling to respond, not saying that we don't owe you an answer, but we are responding. I was there when they announced new resources that government is putting down on research. That's amazing. That research is global. It isn't just for South Africa. It's about a vaccine. It's about a possible cure. It's for the whole world. It was cut. South Africa announced 400 million of its own rand and is inviting Gates and SIF to complement it so that the research can continue. So for me, I see our countries stepping up, civil society stepping up. I went to your clinic and I found there people who are still showing up to support LGBTQ people, but who don't have a salary. I saw the same people in Benin, in Cote d'Ivoire, where they laid off people suddenly, USAID contracts. People are showing up and saying, we gotta be there and bring people, connect people with services. So it's a mixed story about a pushback on closing space, pushback on rights, funding gone, but heroes who have always fought continuing to fight. It's painful, but it's also inspiring to see.
Yes.
And we saw that. Sorry, Yvette, go ahead.
No, I'm glad that you mentioned that, because many of the organizations in countries really are continuing to do the work without the funding, because we actually know what it is. Some of us were there when things were really tough, when our friends were dying. So mainly we do this because we don't want to go back there. And Linda Gale, in her presentation at the opening of IAS, did mention and did show really, really, how we were and how difficult it was. So that almost trauma of us not wanting to go back is there. And I really want to salute some of our community members who continuously are going out there. But there's a lot of talk, Ben, before you come in, around transition, or is it integration, or how are we seeing this play out?
Let's come back to integration in a minute, because I know that's going to be a bit of a firework conversation for us. But just to add that our friend Emily Bass had a piece in the New York Times last week highlighting exactly this point in Uganda and Tanzania, that community workers were showing up without salaries, without any certainty about their futures to keep the good work going. The one thing that I wanted to raise with you, Winnie, was, one of the things that I found quite inspiring is the way in which national AIDS programs, obviously one can't generalize, but how there is an intention to say, okay, we were sort of in this during COVID, we were on our own. We're on our own again. And here's what we have to do. And the HIV Leadership Forum that I know UNAIDS supports released a report back in October last year, very prescient, sort of setting out the steps that needed to take place for transition to full national ownership. I mean, that obviously has now, if you'll excuse my language, has to be put on acid so that they can move very readily. And of course, the report is available on the UNAIDS website. We'll include it in the show notes. So I just wondered, and I think this ties into the question that Yvette was coming to around integration, how you are seeing countries joining the dots between the different funding buckets that they already have to try and pull together and knit together as much of a comprehensive AIDS response as they can.
Then, this question of integration is most relevant for the low-income countries of Africa and also some lower middle-income countries in Asia. And why is that so? It's because it is in those countries where they received a large amount of external assistance, particularly from PEPFAR. This assistance was structured as a parallel program that was good program, delivering good results, but really mainly owned and managed by the donor, sitting outside the health system. Now, with this defunding, it's important that a government owns its HIV response and can only own it by making it part of its broader health system. Goes without saying. Now, while this is happening, in bringing the HIV response into the broader health system, the HIV response finds the broader health system also changing. One, it is moving towards what we often call universal health coverage. And every country is going about it in its own different way. But the whole idea is how to fund the broader health system through collecting resources from those who can and paying for those who can't. That's how simply I can put it. Now, this agenda is slow in some countries, faster in others. In some countries, it is a road to a dead end. You find that people are being given a package, universal health coverage, which expires at the first instance of an illness. You go, you do one test, one X-ray, and maybe one lab test, and it's finished. You're on your own. That's universal health coverage for you.
It sounds like American healthcare.
Exactly. Then you have a country like South Africa, which has a national health insurance plan that is seeking to achieve equity. They had a health system that was providing so well for 15% and providing nearly nothing for the 85%. Now they're trying to turn it so that it serves everybody. They meet resistance from the private sector who deliver services and the producers of commodities and what have you. So you find that each country has its unique problem of how to ensure coverage for all. My answer is, really, there is nothing more important in the social contract, the relationship between people and their government, than giving them free health care at the point of delivery. And it is possible. Many countries have achieved it. Many countries still have it. But this whole idea of making people pay partially, people pay their taxes when they are well and working. When they fall sick, they need care and the state should provide. That is my belief. I don't go away from it, but I can see that a world that has been moved by neoliberalists has put in the minds of people that you should be paying for your health. You're paying when you're already alive and working and having children and producing the future generation of people for the country. You're already working. But when you're sick, the state should care and should pay for you. That's not the time to ask you. So anyway, these insurance systems, some are working well, some are not. But now the other change that our HIV finds itself in is that on primary health care. Many countries have systems of health that are focused on curative, that they fund big hospitals in the cities. There is no prevention work on the ground that is helping people prevent disease. Now, how can you build an HIV response on a system that is not preventive? How?
Yes.
You can't. Most people in rural areas in these countries with a high burden, most of them lack the basics in life and the knowledge on how to prevent disease. So, but then some countries have models that work like that are built on it. I went to Cuba. I was amazed. Their Cuban primary health care system based on a village clinic with its doctor and some community health people takes care of HIV at that level, most of the needs, your prevention things, your ARVs, and then you can be referred as you get complications. But most prevention campaigns are happening all the time. So we are being moved into broader health systems that are not calibrated to do the things that have brought us success, like communities, like community-led services, like community-led monitoring. These are absent in their system, which is becoming more fragmented, more about money.
You've captured, Winnie, the tension that exists, very amicable tension that exists between Yvette and myself over integration. And I'm of the sort of, the HIV response has to integrate or die, given the budget constraints. But Yvette, I'll let you requote yourself from the Rwanda AIDS conference when it comes to.
No, Ben. I think this is a family-friendly show. But I must say the reason why, and Winnie knows a little bit about this, the reason why community is so afraid, I don't want to say we are against, we are afraid of integration. It's because of the fact that we know that some of these systems, this funding, these the clinics that were in the communities, the mobile clinics, the mobile testing services that looked after transgender LGBTQI communities were there because there was a reason for it. And now that the funding is cut, we are not having that conversation. I'm not against integration. I really would like to see integration happening. I'd really like to go to the clinic, feel safe. Nobody's stigmatizing me. Nobody's stigmatizing a trans person. But that is not the case. We need to really, really start doing that social contracting that Winnie is talking about. Really talk about how our governments are going to hold responsible healthcare workers, but they cannot do that in countries where the community is actually criminalized. So we are not against it. We are saying make the systems friendly for people to access health, to want to seek health. South Africa is a great example of that. But within that system as well, do we know that the trans communities feel afraid because of stigma? The trans communities don't want to go because of the interrogation. Young people do not want to go to clinics. I work a lot with young people, and young people would tell me, Yvette, why should I tell people my whole life story just for a bottle of 30 pills to prevent myself from getting HIV? So those are the things that we need to talk about. The demedicalization, you spoke about HIV prevention. The demedicalization of HIV prevention needs to happen for young people to access it where it's free. So if we talk integration, I'd like to see young people free, go to where they party and find themselves PrEP. Go to where, because we know young people have the education around PrEP. So they have an opportunity to pick up condoms. Our systems are so over are almost like policing, that we are okay with condoms, putting condoms everywhere. If you drive in South Africa, you go to the rural areas, you stop at any garage, you'll find a condom. But the only problem we have with the condom is that people take it, or are they going to use it? Do they use it? We do not know that. So we need to also start thinking around how do we integrate. And I like that Winnie spoke about lenacapavir and its possibilities for our countries and what it can do to the aversion of HIV infection, especially for young women and girls. The SADC region is really, really struggling with bringing the numbers of young women HIV infections down. And that is where our big headache is. My and Lillian's headache is the fact that we see young people still getting infected, and it cannot be that way. We need to ensure that they go to clinics, they access their medication, and also in a free space where they are welcomed.
So,
I
Winnie,
agree with you, but
oh,
let me say this about integration. We are trying to look at this across each continent, each region, and to draw out the best stories, the good practices of good integration, and what shouldn't happen. But a critical part is what you've said. Integration must mean that communities are part of the delivery of services, that services work for those who are affected. Now, if that means separate services, it should happen. They said to me that they are training, some countries told me, we are training our health workers to be not to stigmatize and discriminate. And I said, that's great, continue. But I asked them, I said, you tell me, if somebody had told you that in apartheid South Africa, all the white people are going to be trained how not to be racist, would they have stopped? It's the same thing. People have got their ideas in their head, they get them from their churches, from their whatever, their cultural institutions. They've got their fixed minds about what to value and what not to value. Training is one way of sensitizing, but it doesn't always work. It doesn't change people. If training could change people, we would have a holy world.
and the institutions that go with that sort of these folks are embedded in. It's the institutions that are discriminatory, potentially even persecutory, and this is the problem, isn't it? Because we're going to have less money. We're going to have to try and consolidate our prevention, our testing, and our treatment work. But how do we do it in a way that means that the people who are most affected, the groups that we've spoken about, how do we make sure that they feel welcome and that they're not being put at risk by having their information about their personal life, which, may be criminalized in some settings, that then goes into a government record?
Exactly. It's how you structure those services and who is serving who. And also, where is the voice of that one who is being served? Are they commenting on what services they need? These elements of the HIV response need to be retained in integration. You cannot have integration into something that doesn't work for those you're integrating. You change it so that it works for them. And these are the revisions, reforms that we are going to be, that need to be made more quickly now. There are urgent reforms to make services work for people living with HIV and people at risk. This is going to be the big part of our agenda in the next 2, 3, 4 years, helping governments be thoughtful about how to structure services so that they work. You can have people. One person in a clinic in Soweto said to me, I might have everything. It was a male clinic. I might have everything I need here, prep, what, but it will expire here in my clinic because people aren't coming anymore. Yeah, he said, I used to have 2 people paid for externally who were going out in the community and finding those who need and bring them here. Now I'm not seeing people.
Yeah. And that is important because we have those we have those examples, we have those successes. In TB, we called it old fashioned, the dot system, where we were connecting the dots. People were identifying in the communities those who need services. So that integration has to include communities. Then civil society advocates will be okay. And we will all be happy about that.
Yeah, we need to make sure governments do that.
So let me take us back to something you said earlier. And actually it's a question really for both of you. I'm really intrigued to know how you see this playing out. Winnie, you spoke about the decolonialization agenda. And I remember a former colleague, actually of UNAIDS, a couple of years ago saying to me, decolonialization, it's just now the donors coming in and saying, we're going to educate you on how to decolonialize your health systems. But this time round, and I think because of the collapse in US funding, something's happened, hasn't it? It's as if countries are saying, you know what? Okay, you don't want to invest in us. You've put us on a very rapid notice. We'll go and do things our own way. But when you come back and say to us, we need you to monitor and evaluate your services in this way, you need to buy these commodities from these suppliers that are northern. Thank you, no. If you want to come and support our programs, that's great. But you support us, not the other way around. Are you seeing a sort of systemic shift in the way countries and implementers are thinking about their relationships with donors?
I'm seeing, in particular with HIV, more rhetoric than action. I would like to see more action. I'd like to see, governments were caught off guard. They had long been sleeping on the switch. If for 20 years your HIV response has been funded 90% externally, for heaven's sake, where have you been? You haven't even been moving to own it a bit. So some countries were taken by surprise. And so they have to calm their people and say, we'll manage. We're going to manage. But then we want to see them take this as a life and death issue and reallocate money quickly for it. Only a few are doing that. I think we sampled 6 countries in this report we released. 25 countries out of 60 told us they had found ways to increase spending on the HIV response. We'd like to see more of them. But secondly, if they are going to own the response, every region will have to be able to produce its own medicines because it's about the cost of these commodities. It's the cost of these commodities. So we need to see Africa moving very fast and fast-tracking integration of the market, African market, and making medicines, life-saving commodities, the first to be produced and sold globally.
Yeah.
That's where we want to see fast-tracking. And I'm looking forward to the G20 meeting in South Africa, where I hope to be. I'm going to be there with our Global Council on Inequalities and Pandemics, talking with these governments about support the agenda for regional production of medicines, starting with Africa. Brazil is supporting this such a coalition and is leading in the G20. We want all governments put money down. Let's start by producing lenacapavir. Let's make sure that the market is stitched together and one producer can produce for the region. So these are things that are urgent, and I'm seeing developing countries, particularly African countries, saying they are going to do them. I'm waiting for the action. But we, the UN, also have our own story. We also have our own story. So now we are also defunded just like the countries we serve. We have to ask ourselves, how do we keep our support without being, how do we keep our support in a different way with less money? So we too need to decolonize ourselves. Why should a government pay our fat salaries and privileges as UN people. I'm saying this with humility and sincerity. If we are going to remain there to do the data, do the policies, guide the country's support, we too must now look at our own structure. It's also a colonial structure of highly paid people who work in very expensive ways and offices. Hey, it's got to change. So the decolonization is on all sides. On all sides, and I'm aware that even the change I'm pushing here at UNAIDS is painful but necessary. Where there's no justification for us to have all these privileges anymore. They have to go.
Yeah. No, thank you so much, Winnie, for that. And I work a lot with young people, as you know, because I think the next generation of leaders are amongst us. And I heard from your discussion two things. So I speak to my daughter a lot, and she was telling me, don't you think decolonization is co-opted until the funding cuts? And then we started seeing our governments really standing up and speaking around how this aid was not as big as it is. So our governments also relaxed. I spoke to a lot of people and they were saying, the AIDS funding just started being really dependent on foreign aid. And that was not how it was initially. Secondly, also, as we talk about this, our governments growing, we must also, and growing into serving their people and giving them the health care, we must also remember that young people are listening. I listen to Nomonde, and I know you know Nomonde, young Nomonde. She's a young person living with HIV. And she listened to our government talking about decolonization in a manner that was very stigmatizing, saying we need to have short-term losses for long-term gains. And this young person felt she was the short-term loss because if she does not have access to a medication, this means, so we must also not forget that the big brother clubs are at play. The boys club, they are competing, they are showing muscle, they are showing that they can do it without the funding. But we need to be, like you say, we need to be a little bit humble, bring in humanity to say, why was this aid given in the first place? Why did we have aid? It was a agreement between governments to look after each other and to have all of those datas that people are collecting. And it's very, very difficult time for young people who were the ones who did the peer-led monitoring. It was the young people who go to the community and bring people in. So the decolonization discussion needs to happen without the big brother, I want to show off. It has to happen in a humane way where people really realize that the aid was to aid and to help people. And PEPFAR did do a lot in our countries.
Absolutely. Yvette, and Ben, first you've touched a very important point here. The issue of global solidarity. The global solidarity was about, and is still about, governments recognizing that global problems need global solutions. A pandemic is global. Some countries can move faster to control it because they have the means, the wherewithal. Others can take longer, but if you don't eradicate it globally, it doesn't go away. So fine, that was there and remains there. But now, and I see hope. My hope comes from many things. Recently, young people in Kenya went on the street against taxes. They say these taxes are we don't have jobs, we have nothing, and you are hiding taxes on us. And in fighting their government on a tax bill, they also called out the IFIs. They said this agenda of taxing us like this is coming from you, the IMF and the World Bank. And so they called out an injustice in the global system. This is very important. Young people understand it, and we must continue to tell them that aid was put there as a flow of funds to help developing countries fight a global problem. Right. But the same developing countries lose out on bigger funds because of the same system that has rules that disfavor them. There are rules on taxation, global corporate taxation, that allow many countries, many companies to extract, make business in developing countries and externalize their profits without paying taxes. That's a huge loss. $88 billion lost to tax havens in Africa. It's lost to, as we call it, illegal financial flows, but most of it is through one way of a tax loophole towards tax havens in the rich countries. That's money lost to our health, to our education of children, and all of that. You have intellectual property rules that allow a company to work in developing countries to develop a life-saving medicine like this lenacapavir or the ARVs. You use our labs, you use our scientists in our countries, you use our people by testing on them. Then when you have your final product, you own it alone. And you hike the price and you deny it to us for years as people die. It's an injustice in the way intellectual property is governed. We have to solve that. There are also issues in finance, access to finance. We end up being so highly indebted. Interest rates they rise because of external reasons. You suddenly have a debt that was so much, it's now times 4. And you are now paying times 5 to debt interest than to your own health. But it's not your fault. You didn't set those interest rates. You do not set the rates in the market. So all those things, if the multilateral system doesn't solve them, we will always be looking at, oh, give us some aid because we don't have enough money. We don't raise enough of our own. No, we have to go away from there. We have to touch the other resource flows that are not coming to us because of unfairness in the global economy. And Africans especially are the biggest losers. We need to say to our young people, the challenge global corporate taxation. The rules there is a convention being negotiated here at the UN to strengthen collaboration so that these companies don't run away without paying taxes. That convention should be signed quickly, negotiated and signed. The usual suspects are refusing to move forward in the negotiation, the rich countries. Debt the same, a way to restructure the debt so that a country can quickly start having the space to pay for medicine instead of paying debt service repayments. These things need to happen. They are injustices to us.
I mean, essentially, Winnie, we have a case where, the donors are saying, look, we'll give you $1 in aid, but in order to have that $1, you need to give us $4 in terms of being part of the multilateral system.
Exactly.
But here's the problem. We've got a global epidemic, almost a pandemic, depending on how you define it. And the kind of structural obstacles that you're talking about, and I fully agree with the strategies that you're saying need to be adopted to fight and resolve these injustices, they're going to take a while. What do we do in the meantime to make sure that people who need services, this young lady you were talking about, Yvette, who feels that she's a short-term loss that the government of South Africa is prepared to accept, how do we change that narrative? How do we change that equation?
Absolutely. There are immediate things we must do because this is life and death. The reallocations are important. The countries that have been receiving a lot of external assistance, mostly Sub-Saharan Africa, must now go to reprioritizing and reallocating for HIV and other diseases that have been cut, malaria and TB. However, it must be accompanied by good spending. That is where the integration agenda comes in. How do you spend the little money you have brought? If before PEPFAR had its gold-plated program of dreams where you could serve 25 young women with a lot of money and initiatives, and now with less money, be creative about how to stretch that money. It might mean, for example, that community health workers at the community level are working on HIV, but also working on TB, working on malaria, and they are doing community health, not just HIV health. That is
Yes.
the kinds of integration we need. So creativity on how to shape new programs that are cost effective, and reallocations must happen. And third piece, respecting, investing in communities, in key populations and women and girls to be part of service delivery. That's critical. To me, those are things that are so immediate. They can't
Yeah.
wait.
Yes, we cannot do without that, Winnie. But also importantly, in countries where there are so many departments, one, let's stop the corruption. We must talk about that. In South Africa, we have so many departments servicing young people in silos. And we spoke about this when you were there. We have the social development, we have the Department of Education, we have the Department of Health. If these three departments can put their money in a pot and service each and every young person as holistically, we will do saving. So not having three different people coming to the schools to do the same thing, but really spreading our resources. And especially after these young people really enjoyed, we must really also remember that these programs really made young people excited about health. So our social development needs to spend more time in schools. Our Department of Education needs to do more than just teaching. We need to understand if a child comes to school without shoes, what does that mean? If a child is hungry, what does that mean? How are the children at home? And we can really, really have fun doing this integration without having the advocates mad.
There's something you could have added, that yes, there is this fragmentation of many departments all getting money to do the same things, and they are all led by tired old men and women like me.
Exactly.
They are not led by young people. They are not led by people living with HIV who understand what people need. No, they are led by a certain generic type of bureaucrat like myself. We have to shift.
Who just refused to retire, Winnie. And I think I'm going quickly into that place,
I am
but
on
I'm
my way
prepared
to.
for it.
I hear both of you, but I realize we're getting to the top of the hour, and there were two questions we wanted still to ask you. You touched on what all of this means for UNAIDS, but obviously when you had to make the announcement of the staff and budget cuts to UNAIDS because of funding flows from donors, many people were concerned that, this really marked the end of UNAIDS. And I think people like Yvette and myself argued very, very assertively that UNAIDS remains relevant, that while we have a global epidemic, the first major zoonotic infection essentially of the 21st century, even though it started just before the end of the 20th century, now is not the time to take the foot off the pedal. So given what you've had to do, what is your vision for what UNAIDS does in this next phase? You mentioned data, you mentioned policy and advocacy. The country coordinators, the country directors have been so crucial to so many countries. What will you be doing next?
Thank you. I have to start by thanking you, Yvette, Ben, and others like you from civil society who have spoken about the importance of our role and called for it to be protected. Thank you. We're at our best when we are in a country, we are close to communities, to civil society, and we are like a broker, getting them close to governments establish the links to deliver together, defending rights and policies, and of course, the other things on data. Now, we have said, just like, and the people in my organization are also from civil society. Many of our staff started to work on HIV as activists. So we have that relationship, and it's part of the pain we are going through, that people dedicating their lives to this and then having to live when there's a crisis on the ground. It's hard. But we have said we will not die and we will not go away and we will not abandon this cause. So we'll change ourselves and remain there to do the most important things. And here they are. One, we set the direction, the ambition for the global AIDS response. That we must do. And we are already doing. We are making the next global AIDS strategy. It has been adopted in December. We must include targets for the whole world to have ambition. Those targets must be approved mid next year by the United Nations General Assembly. That role of setting the ambition and the direction of the response, we must be there to do it. Otherwise, every country can just go away and do as little as possible. That includes the data, gathering the data and telling the world where we are in the response in order to be able to drive forward. So those roles we keep. On the ground, we will stay close to communities, brokering the relationship. And we are going to measure it. We said we need to measure now. Our countries maturing in their relationship, a structured relationship with communities that delivers results, where they know that communities do this part, we pay for it, they have the space to do. Setting up those relationships and making sure that they deliver is our way of withdrawing by making that relationship strong. We will also continue to speak on rights. Yes, we are the only part of the United Nations that push on the rights of LGBTQ people, the key populations. We don't have agreements globally on this, and member states keep telling us, but we have never agreed. We've never agreed on same-sex relations. We've never agreed on sex work. We say ours is a health approach. These are the policies that are needed, and we push the language in. So that role has to stay, because the UN must keep progressing on embedding rights of all people in our instruments. So those are the roles that we are going to remain on the ground doing, and reorganize ourselves and be in fewer countries with the highest burden and do multi-country offices and all of that. But those are the roles. The integration agenda, as I said, is critical. That is about how do you move towards sustainably financing your response. We would work with governments and civil society on how to define those sustainable pathways. That's it. That's what we want to try to do. And as always, change is hard, but change is also opportunity to do better. Yeah.
Yeah. And just to mention, we've done some great work in the past, and I'm just thinking about the JIPA principles as you talk about integration, is that now we really need to see our governments hiring people living with HIV openly.
Yes.
Especially in the healthcare system, we really need to see the GPP principle of the greater participatory practice, where people who are part of research are part of the studies, and as you say, ensure that the medicines become available. All of these don't happen in a vacuum. There are advocates, there are peers working behind the scenes, like, for instance, lenacapavir, that is really providing drug to the study participants. Those things did not happen in a vacuum. Those things were not done previously, but advocates continuously fight for that. And that is why when lenacapavir is approved in South Africa, we are going to ensure that people who need it the most, who are young women and girls, and key populations get it first. So those are the things we need that you talk about so passionately, that we've worked hard for, and we cannot lose those gains. Those are I want to say those are our gold stones, the things that we hold dear to our heart, and we don't want to lose the reports. We don't want the yearly reports that we launch and we speak about. Those are our marching orders. As a feminist, as an activist, when we say marching orders, is that we clear the path. We are saying this is how we're going to move, and we don't want to lose that. And we hope that we can have, and I'm glad that you continuously engage with our governments so that we have those open doors to discuss some of these very difficult conversations. What was very stressful for us is when we started fighting and holding our government accountable. They likened us to AfriForum. I'm still paying.
That was unfortunate, I must say.
AfriForum is a racist organization, and I am not racist. I fight for my community. So Ben, yes, bringing me
you had the government's back on the wall.
like we always
I'm
do.
sure they regret saying that. That's not right. No.
And they won't hear the end of it until they apologize publicly to us.
Hey, we are counting on you, South Africa, your movement on HIV, one of the strongest in the world, to push on lenacapavir and any others that may come that are long-acting. Lenacapavir being sold on the American market at $28,000 per person per year, when researchers have told us that it could be as low as $25 per person per year if rolled out to the numbers of people we have on our continent who are at risk. Why do they want us to move? Are we going to first have millions of new infections before they bring it down? Help us. Raise the voice.
Yes, South Africa must take up lenacapavir, and we need that support. But we also need to continuously be in engagement with Gilead to say, bring the price down. By the way, Gilead still haven't told us the price. It's still a mystery. We tried to speak to them at IAS. They still say they don't know the price. But we will force. We've done it before. We'll do it again.
Yes, there's a wonderful long history of treatment activism that is kicking into play.
I'm talking to the activists. You and Yvette have been part of this movement for so many years. I have great respect for you. And you're the ones who brought about the change. And this change we need, you will push it through. I don't doubt.
Well, what a wonderful upbeat way to end this conversation. Winnie, there is so much that the AIDS response needs. And I guess, Yvette, isn't it right to say we've got your back? And, we stand solidly with you.
I know it. I am going to get everyone at UNAIDS to listen to this podcast.
Yes, to say watch out.
They need to hear you and what you've just said. Thank you.
Well, with that, thank you to my co-host, Yvette Raphael, and a deep, deep thanks to Winnie Byanyima, the Executive Director of UNAIDS. Thanks also to our director and producer, Erica Spera of A Shot in the Arm Media. And finally, a big thanks to you. Now, it's that moment where I remind you to like, subscribe wherever you download your audio podcasts, but also to make sure, and especially if you are working with UNAIDS to do this, go to our YouTube channel, www.youtube.com/@shotarmpodcast. Subscribe, like, and smash that notification button so that you'll get advance notice when episodes as important as this one, frankly, come out. So with that, have a great week and a safe week, everybody.
Thanks, Yvette and Ben. Thank you so much.
Thank you.